Okay, good evening. Shall we start? There was some
Yes, sir.
okay. There was some problem in my logging, and that's why the delay. Okay, we'll start with the short case as usual. Can you see my slides?
Yes, sir. Just see the big screen. Yes, sir. Yes, sir.
Okay, thank you, thank you. We'll start with the first case. Now, this is a 60-year-old diabetic, 62-year-old diabetic. He was admitted with history of pain in the back of right thigh, radiating to the back of knee for the last 2 months. It started one day when he tried to get up from the sitting position. The pain did not increase by coughing and sneezing. No history of any backache. According to him, the pain was worse on getting up from sitting position and was present at the beginning of walking and disappears after walking for some time. He also complained of paresthesia of the dorsum of the foot, that is on leading question. In the past, he had had an accident 5 years back, sustaining fracture of the right leg, for which surgery was done in the right leg. So this is the history. I think it's Malayalam, but still you can make out what the patient is trying to say. He's telling the pain is radiating down like that.
ഇരുന്നിട്ട് എണ്ണിച്ചപ്പോഴാണ് ആദ്യം കണ്ടത്. നടന്ന് കുറച്ച് കഴിഞ്ഞപ്പോൾ മാറും. നടന്ന് തുടങ്ങി അത് കുറച്ച് കഴിയുമാണ് വേദന. പെരുപ്പുണ്ട് ഒരു 2 കാലത്തേക്ക് അല്ല ഇവിടെ അതാണോ അടിയിലാണ് അവിടെ
numbness
അടിയിലില്ല.
That is injury which was sustained earlier.
Okay.
Okay, that's history. Whatever he is telling that he has got pain in the back of the thigh, radiating to the knee, and he has also numb. That is the site which has shown the injury which has happened earlier before that. Now coming to the examination. Inflection was normal bilaterally. The extension normal. Questionable weakness of the lower expression on the right side. Is there also mild weakness? Doubtful, we are not sure about it. Flexor helicity was normal. Hip adductors and abductors also normal. Knee jack right side is well elicitable, left side is not elicitable. Both ankle jacks were absent. Pandora is indefinite. He was telling mild numbness, difference on the right side. First of the areas is normal. He said normal. You come on straight leg stains, combined pain in that area which is pointing it out. The back of the thigh and the gluteal region. Okay, on examination, findings confined to this is a short case, confined to the right lower limb, tone normal, power all normal except for the mild weakness of the right EHL, Corey dorsiflexion of the ankle. Detail, right knee jack is well elicitable, left knee is absent, both ankle jacks are absent. Sensory mild impairment of pain over the right dorsum of the foot. SLR combined of pain towards the terminal part of the SLR beyond 80 degrees. So what this is the finding. So what do you think the possibility will be in this picture?
Sir, radiculopathy.
Yeah, most likely radiculopathy. That's what we normally consider radiating pain. Even though it does not increase by coughing and sneezing, that's the thing you have to keep in the back of the mind. So what do you like to do?
Sir, is it a piriformis syndrome?
But it was combining pain back of the thigh, not in the gluteal region.
Okay, sir.
So what test you need?
MRI,
MRI, LS pregnancy.
Okay.
MRI,
This
gluteal, lumbar and
yeah.
gluteal.
MRI came with the MRI. This is the MRI. This only I didn't show the video. Only the cuts are there. I taken copied the cuts. There is no obvious pathology that is. This is axial cut. I'll show you one by one, above downwards. So no obvious disclusion, anything seen. Then what do you want now? Probably like to treat or you do something else in this patient.
H reflex, sir.
NCS you want. Okay, NCS was done, NCS was normal. Including
H
reflex.
reflex, sir.
Normal. I did not show it since it was normal.
Ultrasound of the back of the thigh, sir.
Why? What for?
Other possibility could be a rupture of the hamstring tendons.
Okay, very good. Perfectly right. So see this part of the video. So the thing is which we don't usually do. So you have to put the patient on prone position. Here tenderness that area. That's area is converted.
ഇവിടെയുണ്ട് ഉള്ളപ്പം പറയണേ ഇപ്പോഴോ ഇല്ല ഉള്ളപ്പം പറയണം ഇപ്പോഴുണ്ടോ ഉണ്ട്.
So what do you need now? ESR normal, CPK normal. So MRI of the thigh was done. It's MRI of the thigh. As Umar said correctly, this is, you see the hypertensity in the hamstring muscle.
ആ കാണുന്ന ഇസ്റ്റിയോബ്രോസിറ്റി ആണോ?
That is ischal tuberosity from which the muscle is or tendon muscle is or
ഹാംസ്ട്രിങ്ങിന്റെ ഹാംസ്ട്രിങ് അറ്റാച്ച്മെന്റ്.
I'll show the other cut. This is the another axial cut. You can see the and so the next will be more easy to understand. Let us see this one. I will show that one. That is the tendon of the hamstrings. And inflamed surrounding that is inflammation, hypertensity. That's also partial rupture. So I'll show that part once again. This is the tendon. This is the tendon, which is enlarged hypertensity surrounding that in tendinitis. And there is a partial tear of the. So in fact, hamstring muscle tendinitis is tendon, as Umar said correctly. But I did not suspect it initially. The reason I'll tell you why. I thought a local pathology, maybe some myositis, something like that, or some other tumor. Because usually in tear, it does not occur in getting up. Some trauma should be there or weight lifting should be there. That was not there in this patient. This is one day when she got up from the sitting position, she got that pain. So that was very odd for a tendinitis and tear. So the lesson is that when you don't find any radicular lesion to account for the radicular pain, always ask the patient lie on prone position, palpate the back of the thigh and the gluteal region. That is the reason why I brought the case on. It's a very short case.
Sir, how to differentiate from piriformis syndrome, sir?
Piriformis, the exact tenderness site is entirely different.
So more up.
More up. The gait is sciatic foramen. And there is also one test by which you can elicit the piriformis pain, pain due to piriformis syndrome. But here in the back of the thigh, in the region of the hamstrings, where I pressed the back of the thigh. Okay, that's a short case only. Okay, shall I go to the next case? This only lesson is to look also the palpate always back of the thigh, which we don't do usually, to be frank. When you think of root pain, SLR is positive, okay, give him bed rest and things like that.
Sir, we need to refer the surgical opinion. No, sir?
Now, I asked for an ortho opinion. He said that I never
Orthopedic, orthopedic. Yeah, yeah.
Orthopedic, yeah. Orthopedic's opinion. He said you can give anti-inflammatory drugs and see. No need to do any surgery at this point of time. There's only partial tear. He was also surprised that there is no precipitating factor for the tear. Okay, shall I go to the next case?
Yes, sir.
Yeah. This is a story of a 60-year-old man. He gave the history of difficulty in speaking in the form of severe slurring of speech, difficulty in swallowing, difficulty in spitting saliva for the last 3 days. His past history of left hemiparesis 2 years back, from which he has improved almost totally. So history is a short history. 3 days history of difficulty in speaking, the form of severe slurring of speech, difficulty in swallowing, and difficulty in spitting saliva from the mouth for the last 3 days. Past history of left hemiparesis and known case hypertension, diabetes on treatment. So this is the video. Have a close look at the video.
പേര് പറഞ്ഞേ പേര് പറ.
The name.
ഉറക്കെ പറഞ്ഞേ, കേൾക്കുന്നില്ല. ഓക്കെ,
This is how he's
ഇടത്തേ
speaking.
കൈ പൊക്കി വലത്തേ ചെവി തൊട്ടേ.
Ask him to touch the right.
Okay,
His
മതി,
comprehension is
മതി.
normal.
ഇതിന്റെ പേര് പറഞ്ഞേ.
Ask him naming of the object.
പേന. ഓക്കെ,
He
ഇതെന്താ
said
കൈ
correctly.
കിടക്കുന്നേ? വാച്ച്. ശരി, ഇനി ഞാൻ പറഞ്ഞ പോലെ ചെയ്യണേ. ഞാൻ ചെയ്യുന്ന പോലെ പറ്റണില്ല. കണ്ണടച്ചേ.
Ask him to
കണ്ണ്
close the eyes.
മുറുക്കി അടയ്ക്ക്. അങ്ങനെയല്ല, മുറുക്കേട്ട. ഇനി മുറുക്കിക്കേ.
Close it
നല്ല
like
പോലെ മതി. കണ്ണ് തുറന്നേ. കണ്ണ് തുറക്ക്. നല്ല തുറന്നേ. ആ, നെറ്റി മുകളിലോട്ട്. കണ്ണ് തുറന്നോ? നെറ്റി മുകളിലോട്ട് നോക്കിക്കേ. ഈ നൊന്നര കാണിച്ച്.
Ask him to show the teeth.
ഈ അത്രയേ ഉള്ളൂ. ഇനി നാക്ക് നീട്ടെ.
And you put
കണ്ണ്
out the
തുറക്കില്ല.
tongue.
ആ, ഇനി ഈന്ന് കാണിച്ച്.
Again, ask him to
അടച്ചു
show the
പിടിച്ചോ.
teeth.
വാടയ്ക്ക്. അല്ല, വായ അടച്ച് പിടിച്ചോ. അതിന് ഈന്ന് കാണിച്ച്. ഈ
This is all he cannot-
നല്ല പോലെ വരട്ടെ.
Even then
ഒന്നര
he said,
കാണിച്ച്.
okay.
ഈ പോലെ കാണിച്ച. ഊതിക്ക്.
I ask him to whistle.
കവള് വീർപ്പിച്ചേ.
Ask him to
കവള്
blow out the
വീർപ്പിച്ച്
cheek.
ഇതുപോലെ. ശരി, നാക്കൊന്ന് നീട്ടിക്കേ.
Ask him to
നാക്ക്
put out the
നീട്ടിയിട്ട്
tongue.
അങ്ങോട്ടും ഇങ്ങോട്ടും തള്ളിതേ.
Ask him to turn
ഇടത്തോട്ടും
in the
വലത്തോട്ടും
nose
തള്ളിക്കേ.
direction.
തല അനക്കരുത്. തല അനക്കാതെ നാക്ക് വാ തുറന്നേ. നാക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും തള്ളിക്കേ.
He said he could not do that.
അതണ്ട, പറ്റുന്നില്ല. നോക്ക്, ഇടത്തോട്ടും വലത്തും. വാ തുറന്നിട്ട് നാക്ക് ഇടത്തോട്ടും വലത്തോട്ടും തള്ള. വീർപ്പിച്ചേ. ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ. ഇടത്തോട്ട്
He's very
വലത്തോട്ടും
trying to
തള്ളിക്കേ.
move. He's moving his
നാക്ക്
head
നീട്ടിക്കാൻ
rather than
നോക്കട്ടെ.
the
വാ തുറന്ന്. വാ തുറക്ക്. വാ തുറന്നേ. നാക്ക് അടുത്തോട്ടും വലത്തോട്ടും തള്ള. വലത്തോട്ട് ഇടത്തോട്ട് തള്ള. ഇനി 2 വശത്തോട്ടും തള്ളിക്കേ. പറ്റണില്ല. നാക്ക് നീട്ടിക്ക.
So that's the story.
പേര്
Rest of the examination normal. Examination only left hemiparesis. So on examination, severe dysarthria, almost unintelligible, near to mutism. Comprehension normal, no word finding difficulty, no naming difficulty. Had bilateral facial weakness, left more than right. Cannot say E, cannot blow the cheek, and cannot whistle. Decreased parietal tongue movement, cannot protrude the tongue or move it sideways, more up, more towards, affection is towards the left side. Jaw check is normal. No emotional incontinence. So this is, you want to see the video once again? I can show. So what is the likely diagnosis in this patient?
Opercular syndrome.
Very good. Opercular syndrome. Very good. Any other possibility?
Second possibility would be a pseudobulbar palsy, sir, because in the past they have a past stroke and the new new stroke as of.
Yeah. Okay, right. So let us see this one. Now, the first possibility, as you said, is mostly anterior syndrome or Savani-Mary syndrome. But that is not the thing I want. Why not element paralysis bulbar palsy? Why not cerebral palsy? Why not orofacial epilepsy? First one, minor element weakness in the bulbar muscle. His jaw jack is absent. He has got no palatal movement, hardly any palatal movement.
There is no wasting. It's too early.
Acute presentation. We can't expect a wasting in this patient.
Because this
Bell's phenomenon not seen.
Pardon?
Bell's phenomenon not seen.
But the Bell's phenomenon is applicable only if there is only almost near paralysis. It's not a partial weakness. You don't expect a person to be present. In human palsy also, you can be not going to differentiate between the two if there's only partial facial weakness.
What about facial reflexes?
No facial reflexes. Not exaggerated.
We have to look at the gag reflexer, whether it's a
Gag
present
is
or
absent. Gag is absent. Gag sometimes also when only all that time. Maybe in this case it was absent.
look for the shape of the tongue, sir, whether it's a spastic, whether it's a rounded or.
No, that you already seen, no? He is not able to protrude the tongue at all. Once he was able to move to one side, most of the time when asked to move the tongue, he's moving his head rather than the tongue.
Multiple cranials at the same time because bilateral tongue, bilateral facial, it's so.
Yeah, so how does
So the
it
speech, it's not a speech is not of bulbar elements.
No, he's hardly has a voice out. I'll tell you. Only minimal voice is there. I'll show the video once again. That's all his speech.
കേൾക്കുന്നില്ല. ഓക്കെ, ഇടത്തെ കൈ പൊക്കി വലത്തെ ചെവി തൊട്ടേ. ഓക്കെ, മതി. ഇതിന്റെ പേര് പറഞ്ഞ് പേന. ഓക്കെ, ഇതെന്താ കൈ കിടക്കുന്നേ? വാച്ച്. ശരി, ഇനി ഞാൻ പറഞ്ഞ പോലെ ചെയ്യണേ. ഞാൻ ചെയ്യുന്ന പോലെ. ഇതിന്റെ പേര് പറഞ്ഞ് പേന. ഓക്കെ, ഇതെന്താ കൈ കിടക്കുന്നേ?
It looks like a spastic speech. It looks like a spastic strain voice.
No, that's very difficult because it's only like that.
But the patient almost looks like a mute patient.
That's
like,
correct.
yeah.
Almost
So
like,
this cannot. This we first will have to think about. It is not an upper motor type. It looks like a more of a lower motor. Lower motor because of the fact that he has got both-sided involvement, more in the left side than that of the right side.
Right.
And this is that basically it's not a language problem. His comprehension is all right. He can
naming is also
object. Everything is okay. So whatever is there, it is related to the speech. So we are dealing with a case of dysarthria. And dysarthria is what type of dysarthria? Upper motor, lower motor, etc. But there is no pseudobulbar effect, no emotional lability, nothing of the sort. Gag reflex is not exaggerated. Sometimes it may not be exaggerated. So most likely it is not a pseudobulbar. It's most likely due not an opercular syndrome. If in an opercular syndrome, it should have been in the one side. The bilateral is very difficult to explain by a single type of opercular syndrome. Otherwise, it should be in the bilateral involvement. So it's most likely the multiple cranial palsy, which looks like lower motor neuron type. This is my assumption. I may be wrong.
Bulbar can say the limbs
Emotional-
should also go. If it is such a severe involvement of the bulb with involvement of all the
The
swallowing.
duration is only very
facial
short duration,
palsy.
only 3 days.
I'll come to that. The one thing is that it can go with an element paralysis, nothing like, for example, a G-based like presentation can present like nothing against. But he had a left hemiplegia earlier. So that could explain his predominant affection of the weakness, left facial weakness on that side, as well as inability to move the tongue towards the left side, could be due to all the hemiplegia. Now, question is, you said what you said is that opercular syndrome should indicate may not be bilateral. More often, it's a bilateral lesion producing that. But however, even unilateral opercular lesions can produce acutely something like this. That is a complete loss of speech by bilateral paralysis has been described. This is explained because the patient might have been having a lesion before, like in this patient. A fresh infarct on the other side can produce a unmask a bilateral opercular syndrome. So that is not against.
Is there any volitional emotional dissociation?
That's one you have to look for. Very good. So that will help to differentiate what?
From opercular syndrome from element syndrome.
Okay, element syndrome, opercular syndrome. Okay, right. That we can do, right? Then. Okay, right. And let's see. Now, this is the question I was asking, the three things. Let us see this part of the video now. I'll show the rest part of the video. Then you ask answers and
സാർ എങ്ങനെയാ ചിരിക്കുന്നേ? ചിരിക്കാറുണ്ടോ ഇപ്പൊ നിങ്ങള്? ചിരിക്കത്തേയില്ലേ? ചിരിക്കത്തില്ലേ? അത് കൊള്ളാമല്ലോ. ചിരിക്കുന്ന ആളല്ലേ? ചിരിച്ചു കാണിച്ചേ. ശരിക്കും ഇതാണ് ചിരിക്കുന്നത്. എന്തോന്ന് ചിരി ഭാഷ ഇത്? നന്നായിട്ടൊന്ന് ചിരിച്ചു കാണിച്ചതാകട്ടെ. ഇങ്ങനെയാണോ ചിരിക്കുന്നത്? ശരി.
Okay, what does it mean? He has got emotional moments are preserved. Okay, that rules out an element paralysis. Okay, so you step by step. Let's say it's an element paralysis because it's in element paralysis both will be absent. Now, why can't it be a cerebral palsy and why not our opercular syndrome? How differentiate between the two?
Emotional incontinence is seen with a pseudobulbar, not with the opercular.
But we cannot say yes, no emotional incontinence. Emotional fibers are preserved, that's all. On smiling, spontaneous smiling, the face is moving, that's all.
The Jojek is normal in this.
Jojek is absent, gag is absent.
I mean, in pseudobulbar, the Jojek will be brisk and gag will be brisk. As well as there is a emotional incontinence. Though these things are not here.
So that will favor?
That will favor opercular syndrome, sir.
Okay, correct. No, you can smile spontaneously. So it is not an element palsy. We go by one. So is it anterior syndrome or cerebral palsy? So how will you differentiate between the two? That is the next thing. As I was partly telling correctly, in our patient, the automatic movements are, that's the most important thing. Okay, the automatic movements are preserved. See, if you're looking very carefully, when asking him to push the tongue sideways, he did not do it. But after some time, he did it automatically. When he was trying to do something, he's moving the tongue one side. On laughing, the facial movements are normal. Okay, that can occur with cerebral palsy also. When asking him to show the teeth, if you look very carefully, there was only a minimal facial movements to either side. But when he asked to close the eye, his facial movements right was almost normal. I'll show the video, then you can understand. And there is no spastic speech in cerebral palsy aspect of spastic speech, whereas in the case of opercular syndrome, there is no spasticity. And Jojek is usually absent in opercular syndrome. And let us see the true videos I will show. This is the one. Patient asked to show his
അത്രേ ഉള്ളൂ. ഇനി നാക്ക് നീട്ടെ. അതിന് ഈന്ന് കാണിച്ച് ഈ നല്ല.
But see next video. When asked to close the eye,
കണ്ണ് മുറുക്കി അടയ്ക്ക് അങ്ങനെയല്ല മുറുക്കേട്ട ഇനി മുറുക്കിക്കെ നല്ല പോലെ മതി. കണ്ണ് തുറന്ന് വരട്ടെ. ഒന്നുകൂടെ കാണിച്ച് ഈ.
That means he has got an automatic movement also. Sometimes, some of the movements which you do automatically without an intention. So when you close the eye, the lower part also is going up. It's not intentional. When he's intentionally asking to show the teeth, he could not. But when he's closing the eye, the right eye face is moving upward. That's an automatic movement which is occurring. Similarly, I'll show one more thing. Here, patient is asked to move his tongue to either side.
ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്ക്. നാക്ക് അടുത്തോട്ടും വലത്തോട്ടും തള്ളേ. ഇടത്തോട്ട് തള്ളേ ഇനി.
Okay, very hard. Now, let us see. At times you could do it.
ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്ക്.
Much more movement possible.
നാക്ക് അടുത്തോട്ടും വലത്തോട്ടും തള്ളേ. ഇടത്തോട്ട് തള്ളേ ഇനി.
So that means is only voluntary and there is an association between voluntary and automatic action. So that is an important differentiating point between cerebral palsy and opercular syndrome. In opercular syndrome, there is a voluntary automatic dissociation, not in cerebral palsy. Cerebral palsy, emotional incontinence is there. That's a different thing. That is because the uninhibited loss of inhibition of the facial respiratory syngenitic center responsible for laughing and crying. That is a different thing. That is the loss of inhibition of the laughing and crying center. That is occurring along with cerebral palsy. That is resulting in emotional incontinence. But here is a voluntary automatic dissociation. That is the one which you get in opercular syndrome in view of hypophonic speech, almost anarthria. You see here, just like the professor is telling, it's almost mute state. No spastic speech, no emotional incontinence, Georgiak is absent. The characteristic feature is automatic voluntary dissociation. Points against cerebral bar, no emotional incontinence, decreased tone of the affected muscle, absent Georgiak and gag reflex. And speech is not spastic. So this is a CT and MRI. This old infarct. No, just seen the recent infarct is not in the CT scan, but you take the MRI, you find the acute infarct of the opposite opercular area. So it's a unmasking of the opercular syndrome because of the fresh infarct on the other side, where the patient already an infarct on the opposite side, which was remaining asymptomatic except for the weakness of the opposite side. So he was put on antiplatelet drugs and followed up. This is after 1 week.
Okay. പേര് പറഞ്ഞേ ഉറക്കെ പറ തിരുവനന്തപുരം എന്ന് പറഞ്ഞേ ഞാൻ തിരുവനന്തപുരത്ത് താമസിക്കുന്നതെന്ന് പറഞ്ഞു ഇങ്ങനെ തിരുവനന്തപുരത്ത് പാപ്പാ എന്ന് പറഞ്ഞേ പാപ്പാ.
So a few words about opercular syndrome. Consider clinical syndrome of faciopharyngeoglossal laryngeal paralysis that is innervated by the 5th, 7th, 9th, 10th, and 12th cranial nerves on voluntary movements of these muscles, but well-preserved automatic and reflex movements of the same muscles due to lesions of the cortical or subcortical region involved in the anterior opercular area. Facial appearance is atonic and mouth is half open, just like our patient. Patients with opercular syndrome have severe speech disturbances and almost mute. Chewing and swallowing are severely impaired. The oral stage of the swallowing is severely disturbed in most patients, but the swallowing reflex can be adequate if the bolus is delivered into the pharynx. The tongue is almost immobile. They can cry, laugh, and yawn normally. So it's a cortical type of cerebral palsy. See, if you get bilateral pyramidal involvement in subcortical location, the corona radiata and all, what you're going to do is a typical cerebral palsy with a spastic speech and emotional incontinence. But if the cortex alone is affected, the corticospinal fibers for this muscle alone is affected, you won't have the other features of a pyramidal syndrome. That is why they don't have spastic speech, they don't have emotional incontinence, they don't have any bliss, Georgiak, and gag reflex.
Sir, can they develop this sort of pseudobulbar effect after, syndrome after some time? After some time?
No, they don't develop. They don't develop. That is why the difference between an infarct occurring in the pyramidal tract in the subcortical location or the brainstem and the opercular area.
So how will you differentiate from orofacial apraxia?
That's a wonderful question. Very, 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 very important question. That is another question, another condition where you can have a voluntary automatic dissociation. That's a very intelligent question because suppose in orofacial apraxia, the learned movements are affected, but automatic movements is preserved. Suppose unable to put out, it has to put out the tongue, is not able to put out the tongue. But after some time, you find that when something is itching on the lip, he may put out the tongue and lick the lips like that. Okay. But asked to put out the tongue, he will not. That is an automatic movement. That is what is happening in apraxia. So apraxia is, by definition, is unable to carry out a learned motor act voluntarily. So that is a very good DD of this particular patient. The only point is that in orofacial apraxia, they are never mute like this. Otherwise, difficult to differentiate orofacial. Moreover, if you find, truly speaks, actually weakness, which is you can see in this patient. Now, this is I'll come to the orofacial apraxia later on. Then this one, this is how differentiate between cerebral palsy. I think somebody is drawing on the screen. I don't know.
Yeah,
Can you also
somebody
see?
is scratching. Please don't scratch. Please don't scratch.
These are differentiating features. Cerebral palsy, supranuclear upper motor and bilateral cortical pathways. Opercular syndrome is a cortical variant of supranuclear palsy. There is bilateral opercular cortex or subcortical projections. Speech is spastic in cerebral palsy, unclassifiable in opercular syndrome. Automatic movements are absent in cerebral palsy. They are preserved in opercular syndrome. Facial palsy is human in cerebral palsy, difficult to classify because the reflex is not brisk. Georgic and gag reflex exaggerate cerebral palsy. They are normal or absent. Other lesion reflexes are present in cerebral palsy, is absent in opercular syndrome. Emotional incontinence is present, not present in opercular. These are the differentiating features between cerebral palsy and opercular syndrome. Now, this I think we'll skip that thing. Now, how to differentiate from orofacial apraxia? The same question I'm asked. Is characterized by loss of voluntary control of facial, lingual, pharyngeal muscles in the preserved reflex in automatic appointment, just like opercular syndrome. But orobuccal apraxia is automatic dissociation, but opercular syndrome. But nevertheless, it's difficult to differentiate.
Small infarct on the left side, something like a dominance.
Nothing like that. This is nothing to dominance because actually this is actually a paralysis. Only the corticospinal fibers are responsible for the contraction of the bulbar orofacial muscles are affected. It is nothing to do with the language dominance or anything. Opercular syndrome. I heard previously presented on case of status epilepticus, the benign rolandic epilepsy like presentation in the status producing as neural migration disorders. Then partial status epilepticus in benign rolandic, this is called reversible opercular syndrome. So that's about that thing.
So why the response was so quick with the antiplatelets?
Because he's right, the infarct was only small, no? Initially he had only in that area is there. Luckily for him it reverted.
The presence of Georgic and gag reflex and the acuteness of onset also differentiate this from the apraxia, isn't it, sir?
Yeah, correct. That's what I said. That also differentiate from apraxia. The lesson I would tell you is that the opercular syndrome is not equivalent to bilateral pyramidal corticospinal pyramidal involvement. That's the answer. Generally different. That is why you don't get a syndrome just like a motor neuron disease produce spastic speech or bilateral stroke produce spastic speech with gag reflex and all that will not be seen in opercular syndrome. Okay. Is any if no question, shall I go to the next case?
Sir, can you log out and again log in because there are some markings in
Okay.
the screen.
Right, surely that's a good idea. I'll log out and log in. Very, very good. I'll log out.
Sir, no need to log out. You just
Okay, can you see my slide now?
Yes, sir, we can see the slide, but not the content.
You shared the slide, sir.
Yeah. Okay. Sorry. I
You
not
start
shared.
sharing.
Okay. Just 1 minute. Just 1 minute. Now is it seen?
Yes, sir.
It's okay, sir. You can just make the, yes, sir. Yes, sir.
Okay, thank you. So I go to the next case. This is given to me by Dr. Fiji Chako. He is a professor of neurology in Anterior Medical College. Now, this is a story of a 17-year-old girl who was apparently already till 10 days back. When she noticed difficulty in walking and difficulty in getting up from sitting position. There's no sensory complaint, no root pain, no backache, no bladder problem. About 2 weeks prior to the onset of this weakness, she was involved in jumping game. Tavlachatta. Tavlachatta means they jump just like a frog jumping. Yeah? That is a game they do it. She was involved in that game. That's all the story. Then 4 days after this Tavlachattam, jumping game, she developed this weakness. So this is the I'll tell you once again, she had noted difficulty in walking and difficulty in getting a sitting position. No sensory, no root pain, no backache, no bladder problem. So this is the video shared by viewers and was absent. Upper limbs not lower was hypotomy. Reflection was weak, bilaterally more weak on the right side. Knee action is also weak. Almost weak more on the right side than the left. That is a really good power. Close flexion was weak, more weak on the right compared to the left. HL is also weak. And there was relatively good power, but still weak. Again, more weak on the right side. Adduction was weak on the right side. Left side almost normal. Hip abduction was weak bilaterally, again more on the right side. Knee flexion was weak, more weak on the right compared to the left. That's more weak. Hip action is also weak, again more on the right side. The right side she could not keep it straight out, more weak. Abdominal reflex was intact. Knee jack were and ankle jack were absent. Anterior is subgoing bilateral. Sensations were all normal. Pain was normal. Back also is normal. No area of sensitive hospitality. Is able to feel. So on examination, tone normal in the upper limbs, hypertone in the lower limbs. Beavers negative, power in the upper limbs normal. Power in the lower limb, right 3 to 4. and 4 plus on the left side. Adduction again more weak on the left, right compared to the left. Adductor is also more weak on the right side. Extensor again more weak on the right side. All muscles were weak, more weak on the right side. DTR upper limbs normal bilaterally, lower limb absent, angle jack elicited just after thoracic maneuver. Abdomen reflex intact, plantar upwing bilaterally, sensory system normal. So, where is likely localization?
The sacral sensations.
Like sensory loss, he was, I don't know whether it was done, the perianal was looked for, gluteal region are all absent.
Sir, was there any tenderness in the muscles, sir?
No tenderness in the muscle.
Sir, is it a spinal cord infarction, sir?
Beaver sign negative.
First of all, localization.
It's in the dorsal cord, sir. In the dorsal cord, around L1 segment of the cord with anterior horn cells.
Above L1, you mean to say?
Yeah, above L1.
Beaver
Okay.
sign
Negative.
Is negative.
Negative. Above L1 with spinal cord with pyramidal and anterior horn cell involvement bilaterally, more on the right side.
Which anterior, which level anterior cell?
Because the segment knee jack and ankle jacks are lost on both sides.
So you mean extensive lesion?
Extensive lesions.
Okay, right.
anterior
Okay.
spinal cord, lower spinal cord involving anterior horn cell.
Pardon?
Lower spinal cord involving anterior horn cell. Sparing
Yeah, look. Yeah, right. So it's most likely to be an epiconus lesion, what you're trying to say. Correct?
Epiconus, yes, sir. Epiconus. Coda
Yeah.
must be involved. Coda and
Right.
epiconus.
Correct. Upper part of the conus and epiconus is
Yeah,
affected.
epiconus.
Correct. So that's intermedullary lesion of the spinal cord. Agree. Okay. But why can't it be GBS like presentation?
So why there should be plantar in GBS?
Yeah, the plantar is subgoing. That's against. Okay. Then may myeloradiculopathy.
Radiculopathy is a possibility.
Similarly, myeloneuropathy is also possible. Only
Sir,
thing is acute
extensive
presentation.
epiconus involvement with absolute preservation of sensory is.
Correct. That's the thing you have to keep in mind. So it is not a straightforward epiconus conus lesion. Okay. It could be. You can explain everything, but the thing is sensory is totally spared. That again you have to keep in mind.
The bladder
It's a cortical lesion.
Bladder is not affected.
that also against a conus, epiconus.
Not conus, predominantly epiconus. Epiconus is a good possibility. Conus may not be affected. The central lesion, the epiconus can produce exactly the same thing, except that the sensory is not affected. That's the only point against. In the presence of since sensory is preserved, naturally you have to keep other possibility like a GBS also. Myelopathy may be to something else also, or myeloradiculopathy or myeloneuropathy also you have to keep in mind.
Sir, since there is a bilaterality and extensor plantar and the gross asymmetry of the weakness, GBS is very unlikely. So,
asymmetry is not against a GBS.
Yes,
The only point against GBS is subgoing plantar.
extensor plantar. Myeloradiculopathy, that too without sensory and is asymmetrical.
That of course can occur. It depends on the degree of myelopathy. See, the problem is she has got a weakness is LMM. Joint reflexes are absent. So it can go with a radiculopathy. Then why myelopathy? Because plantar is severely explained by myelopathy. That cannot be ruled out. See, the point is that the first possibility, agree with you, is epiconus lesion, which can explain everything, but the sensations are spared.
In acute weakness, can we differentiate between LMN and UMN by tone and reflexes?
Yeah, that can be, because this is not a acute human can produce hypertonia and reflexia due to spinal shock. But here it is not spinal shock. Why? Because you've got a power there and sensations are preserved. In spinal shock means there is a total loss of motor, sensory, and reflex loss. It's not a spinal shock. So it has to be an element lesion there. Lower limb is element, no doubt about it. And in addition, there is a plantar also. So both can occur in one area is the epiconus.
Sir, suppose there is a medial part of the cord is affected, then we can explain the pyramidal as well as the anterior horn cell, sparing the fracture.
No, that you cannot. Because you are putting a lesion bilaterally, no, not unilateral. If you lesion the middle part of the cord, then you have to go to the opposite side. That means it has to affect the crossing fibers or the pain fibers.
Yes, sir.
Okay.
Yes,
So
sir.
that possibility cannot be explained.
Compression from the ventral part on the cord affecting pyramidal tract alone, is it possible?
Again, you mean to say a compression where anterior to this thing or at the level above in the thoracic cord?
Maybe an atlantoaxial dislocation where there is compression from the anterior part.
Anterior cord, I mean the location. Suppose it is above L1, compression can present like that. But how to explain the absent reflexes? You cannot explain a compression from outside of the epiconus or conus because that is surrounded by the root also. Okay.
Sir, if the compression is hired up with the watershed involvement of the conus, with only involvement of the anterior horn cell, can it cause areflexia of the knee and ankle?
No, it's areflexia is due to the S1 segment involved. L5, L3, 4 and S1 segment is affected. So whatever, there may be a lesion inside the cord, whether it is ischemia or a demyelination, whatever it is, tumor, what it can, that can cause the same finding. The pathology we are not discussing because we are talking about the site of lesion. Even if it is ischemia in the central cord, the reflex should have been, the crossing fibers has to be affected, no?
So very rarely peripheral demyelination can be associated with central demyelination in the cord also.
Correct. It's also, yeah, there can be combined demyelination. I also present some time back a patient with combined peripheral central demyelination.
Sir, one doubt. What is the level of the epiconus? When do we say epiconus lesion? That
I'll tell you. See, in fact, this division of conus, epiconus actually only arbitrary. In the neurology, the neurological terms, you use this term. Actually speaking, that's a very foolish way of differentiating. So, for example, the actually conus by neurological conus means S2, S3, S4, S5, and coxilia. That is the lower 4 segments are called conus. Then the 4 above, that is L4, L5, S1, S2 is called epiconus. But that's only an arbitrary thing. Say, nobody can see your lesion, the conus cannot go up, epiconus lesion can go down. So naturally, it is only not a strict boundary like USA and Canada. So it can go that way and this way. So it's only a group or what you call arbitrary division. Anatomically, conus is defined as that the lower tapering part of spinal cord L1. That does not say this much segment is there. For clarifying our localization, we put such arbitrary division as epiconus and conus. By conus mean lowermost 4 segment, epiconus just the 4 segments above that. A pure conus lesion in that sense will not produce weakness because it was S2, 3, 4, it would bladder involvement, perianal sensory low, those things will occur. But if a conus lesion can go up from S2, you can go this segment above, angle jack will be plantar will become weak, plantar reflex will become weak. So that's why I said it's only an arbit. Okay. So what do we do now? Let us see. So epiconus lesion, that's the first thing to keep in mind. Dot points, no bladder, no sensor. Myeloradiculopathy, prearachnoiditis, possible. Curry GPS, central peripheral demyelination, that's also possible. So What would you prefer in this patient of the three things? If you're allowed to vote for one, which will you vote for?
Epiconus lesion, sir.
Okay. All agree with that? Okay. So this is the thing which you prefer. Intermediary lesion affect the central gray matter, affect the anterior horn cells, which is extending laterally. There is predominant affection element with mild pyramidal signs. Now I will show the picture of this thing. Suppose there's the lesion might have started here somewhere in that L3, L4 region to S1 bilaterally. Suppose there is lesion there started L2 there coming down, can produce exactly the same thing. Because L2 downward hip flexion, everything is weak up to S2. But the sacral segments, S3 segments are spared. That is a bladder spared. So that can explain that thing. Only thing is it's inside the cord, not going outside into the white matter surrounding that thing. Then could it be an epiconus lesion affecting the L5S1 segment, which might extend? That's also possible. It need not be from above downwards, it can be from below upwards also. Same thing will occur. Only thing is ultimately those segments are affected. So this can explain the absent angle check and knee check. The affection of the pyramidal tracts above the L5 segment is produced associated pyramidal cells. The only pyramidal cell is upgrade plantar. Now the question is why bladder is spared? Probably the affection of the pyramidal tract is mild. If it is significant affection of the pyramidal tract bilaterally, bladder you expect to be affected. But it is not affected in this patient. See, this is the anatomical localization. Central cord affecting the gray horn cells. Then the next question is, if that is so, why sensory is spared? See, this is the crossing fiber which are drawn there. That should have been affected, correct? Agree with that?
Yes, sir.
Yes,
Yeah.
sir.
But if I say that is possible, can anyone tell me the explanation why it can spare? Can be spared in lesions here?
Some viral infection can selectively involve the anterior horn cells.
Sir, it
It
crosses
No,
hair
because
levels.
for some
Hair
the
levels.
only
crossing
cause
over is
for
higher.
Hair levels.
That's the answer. See, I'm going to answer the question. Why that is then that is produced affection of the crossing spinal thalamic tracts produced. That is what we expect. Now, a central lesion, the lumbar cord need not affect the crossing pain fibers, unlike dorsal cord or a central cord. You know the reason why? Because if the pain fibers at enters the cord usually ascend one or two segments and goes to the opposite side. Okay. That ascent or the ipsilateral ascent before crossing the opposite side, least in the dorsal cord need to. As it goes upward, the ascent, the relative ascent before crossing gradually increases. So the upper thoracic cord, it is 2-3 segment. The cervical cord, it is 3-4 segment. Okay, then only it crosses. But the maximum ascent is in the lumbar cord. So if you look here, the slant, the crossing is much wide in the case of lumbar cord. So hardly ever any pain fibers reach the contralateral side unless it reaches the L1. I don't know whether I made you understand or not. So normally when you ascend up, then only cross. Then ascent will be maximum in the lumbar cord. So the pain fibers tend to remain on the same side before crossing to the opposite side. The crossing part mainly taking place in and around L1, L2. Till that time, it is going to ascend. So it's so rapidly happen, you can spare the pain fibers if the lesion happens to be in the central part of the conus region, epiconus region. This picture is from Bing's textbook of neurology, where you explain this. Some time back, I had discussed one case of epiconus producing same state pain and temperature, pain loss as well as pyramidal tract, which cannot occur with the cord lesion, but can occur with the epiconus lesion. The individual segments lie close together so that few crossing spinal thalamic fibers passing caudal to the lesion reach the opposite side. They remain confined to the same side. The slant of the ascending fibers is maximum in the lumbar cord, least in the lower dorsal, maximum, and then comes gradually, it goes up, the slant will be more and more up to the cervical region. So here, then the question is why you get the upgoing plantar in the central lesion? That invariably means the lesion has to go laterally to involve the pyramidal tract. Then how can you get upgoing plantar in the presence of LM and paralysis same muscles? Okay, already L5 is LM and how can you upgoing plantar?
Mild weakness, sir.
Correct. If it's a total weakness, suppose EHL is totally weak due to an element paralysis, you cannot get upgoing plantar. Okay, that is why if you get a conus lesion affecting L5 segment downward, you will not get upgoing plantar. It has to be above L5 with L5 segment relatively preserved, or at least some power should be there. Here, EHL dysplasia are affected by element. Then how can a human lesion above produce upgoing plantar? It depends upon the severity of the element paralysis of the L5 innervated muscles. See, you may get an apparent zero power of the EHL, but we do not know that is zero power is due to LM and UM, we can't say. That may you get an upgoing plantar. If you get an upgoing plantar is present, such situation means that zero power getting means that at least part of the weakness is due to a pyramidal weakness. A total element weakness of EHL will not produce upgoing. In our patient, the power was for EHL were around grade 4. That is why he has got an upgoing plantar. If they were a grade 0 to 1, you would not get an upgoing plantar even if there is a pyramidal lesion. If any doubt is there, please clarify, stop and clarify, then can proceed. Okay, any doubts in that? How can I explain all the findings in this particular patient with an Epiconus lesion?
Sir, can you please explain the spading of the sensory once more?
Yeah, surely that I'll explain that. Normally, when the pain and temperature fibers enter the cord, it ascends a few segments in the tract of lesion. Then it enters the synapse with the substantia gelatinosa prolando. That is a layer 2, laminar 2. From there, it crosses to the opposite side and ascend. That is a normal way the spinal fibers enter the spine. The ascent does not immediately cross the opposite side. This ascent is occurring only 1 or 2 segments. This is applicable only in the case of a thoracic or cervical cord. This ascent before crossing is least in the lower dorsal cord. That means if you get a lesion at deep 10, the crossing may be occurring just 1 segment ago. Then the pain loss may be above that. That ascent is gradually increases. So in the upper dorsal cord, upper thoracic cord, it may ascend for 2-3 segments before recrossing. Okay. So there is a lesion there, pain loss will be 3 segments below. Again, if you cross upper cervical cord to the cervical cord, then the ascent will be still more. It will be 4-5 segments. So if there is a lesion is C3, pain loss level may be 3-4 segments below that level. That is because of the lesion produced spinal tract I'm talking. So the fibers which ascend in the tract of lesion is the degree of ascent varies in the as the lesion goes in the thoracic and cervical cord. No, that is not applicable in our that is a general statement. If you look, then ask me why lumbar cord, the maximum ascent is in the lumbar cord. So from lower dorsal gradually increase, but the maximum, much more maximum than more than the cervical cord is the lumbar cord. So what happened means the fibers are entering the L2, 3, 4 segment. It does not reach the opposite side. You still remain on the same side. By that, only when it reaches towards the L1, then it causes more to then reach the opposite side. That is what is depicted here. The fibers which is shown on the right side still remain on the same side. Has not crossed. That is why
this is applicable for only the tracts which are crossing, not the posterior column sensations or any other one.
Only for the pain and temperature, not for
Okay.
posterior. Only pain fibers ascend and cross. All other things just enter and ascend.
Yes. Thank you.
Sir, in case of cervical myelopathy, you get a false localization sign in the lower region. So how can we explain that?
In the cervical cord, that is very easy to explain. I can tell you why. Because suppose you've got in a cervical myelopathy or a compressive myelopathy, the pain may be confined only to the lower part. Say for a posterior column also. For example, if the spinal, imagine the spinal tract is compressed by an extramedullary neurofibro. If you look at the lamination spinal tract, the lower limb pain fibers are most lateral. So when you come, as neurofibro compress the lateral part of the pyramidal tract, pain loss will be on the opposite side, only in the contralateral leg. As the tumor grows and compresses the whole of the spinal tract, the pain loss will gradually ascend up to the level, almost up to the level of the tumor. That's on the opposite side. That is because of the lamination. Lamination in the sense that the sacral fibers are most lateral, then lower limb fiber, then trunk, that comes like that. Okay, that is in the case of pain. So they can have a ascending sensory pain loss and temperature loss in a progressive compression of the cord from outside. Same thing can also occur posterior column, because the posterior column sensations are carried through two tracts, gracilis and cuneatus. The tumor happened to compress the gracilis only, then produces only ipsilateral loss only in the lower limb, tumor wave in the cervical cord. Then the tumor grows and expands onto the upper cuneatus tract. Then upper limb fibers also can be affected. Other way also is possible. Suppose the tumor is compressed the cuneatus first, upper limb sensation will be lost first. That is why many of the high cervical myelopathy, upper limb sensation occurs, sensory loss occurs first before the lower limb. As told before, the first sensory loss usually in upper cervical myelopathy in the little finger. That is because the cuneatus tract is much larger and superficial than the gracilis, which is smaller and inside the posterior central sulcus. A compression is more likely to compress the cuneatus tract than the gracilis tract. Okay, is that clear, Umar? Is it okay?
Yes, sir. It's clear, sir.
Okay.
Sir, one more question. Suppose there is a pseudoplantar. So, how can we explain? Suppose there is no human findings at all, only pseudoplantar.
Yeah. So pseudoplantar is described in three situations. Suppose a patient, before that I'll tell you which are the muscles responsible for the normal plantar.
First.
No, flexor plantar is and the extensor plantar. For the extensor plantar, the extension is carried out by the extensor hallucis longus. The flexion plantar is the muscle involved is the flexor hallucis brevis. Got the point? That is because the movement is occurring at the metatarsalophalangeal joint for the flexion. Okay. Suppose you've got short muscles are affected. So in fact, normal plantar means that it's actually an extensor and flexor bias. The upgoing plantar is actually a physiological flexion movement. Okay. The plantar flexion or the flexion of the big toe is a physiological extension movement. The explanation for that is why man has become biped. Let's forget about that. Remember that thing. So actually, the upgoing plantar is a fragment of a flexion reflexes, flexor reflexes. Now, whatever it is, remember this point. Extensor hallucis longus is responsible for the extension of the big toe in upgoing plantar. The normal plantar is by the flexor hallucis brevis. So in a situation where you get short muscles are weak and wasted, for example, some neuropathy or something affecting the short muscles, sparing the extensor hallucis longus. When you stroke the plantar, instead of flexion, you get an extension. Then you may ask, why should you go extension? You can remain mute, you need not flex. No. Every movement, whether it's a flexion movement or a normal plantar or upgoing plantar, both muscles are contracting. It's a bias which is determining it. In upgoing plantar, it's the flexion bias. Then flexion bias means the extension of the big toe is dominating. The normal thing, the flexor bias, then the flexion movement or the extensor bias is dominating. That is why you get a normally situation flexor plantar, flexion of the big toe. In pyramidal lesion, you get extension of the big toe. Not that if the flexion is not contracting, but the bias or the overaction is more for the extensor hallucis longus. So in such a situation, you get one part is lost means what? The big toe will go out. So in short muscle weakness like poliomyelitis and all, you can have a pseudoplantar. Second cause of pseudoplantar is associated dystonia. Some stimulus may trigger off a dystonic contraction and then produces pseudoplantar. But there the point is that dystonic contraction, the picto will remain extended for a long period of time. Unlike a true plantar that goes up and comes back to normal. In a normal true plantar, the moment the stimulus is taken off, the big toe should come back to the original position. In dystonia, that will not come back to the original position. Is it okay, Sumar? Clear to you?
Yes, sir. Yes, sir.
Okay. So it's actually both are contracting. It's the bias which determines whether it's extension or a normal plantar.
Sir, one more doubt. Can we get extensor plantar in grade 0 power?
No, you can get if it is a pyramidal lesion. Suppose if grade 0 power is to LMN, even if there is a pyramidal, you will not get extensor plantar. If suppose you got a paraplegia, 0 power, you get upgrade plantar. Because plantar is plantar response is by reflex, not by voluntary action. The grade 0 power can produce away provided it is the 0 power is shoot a pyramidal pathology, pyramidal lesion. Any more questions? Okay, I'll carry on with this case. So,
spinal shock plantar is, can we get a mute plantar?
Yeah, in spinal shock, depending upon this stage, in acute spinal shock, all will be lost. Motor, sensory, all reflex, subclavian, everything will be lost, including the anal reflex will be lost. But the first thing to recover when the patient recovers spinal shock is the pulbocavernar reflex as the anal reflex. Then the reflex only with the upcoming plantar, then the reflexes, muscle, and last will be the power and tone and muscle power.
Okay, sir.
That recovery is important to find out whether it's actually an element paralysis there or is a spinal shock.
Sir, we see a lot of patients with acute stroke with hypotone. The tone will be less.
Low, correct.
Without spinal shock.
Yeah.
So how can we explain that, sir?
Two ways can explain that. For all acute neurological syndrome, there can be neuronal shock that can produce hypertonia. That is when sada ordinary renal capsule hemiplegia. But even if it's a chronic lesion, so it need not be acute, can also produce hypertonia, pyramidal weakness hypertonia, if the lesion happens to be in certain particular location. For example, if you hypothetically you cut off your pyramidal tract, only in the, sorry, not pyramidal tract, corticospinal tract, for example, in the medullary pyramid. Or if you put a lesion only in the area 4, touching the other areas, you get hypotonia and not spasticity. Because spasticity is not due to the involvement of the corticospinal fibers. It is because of the associated cortically originated extrapiramidal fibers responsible for mediating the muscle tone. They are coming not from the motor cortex, but from the area 4S and 6S, etc. They are ultimately going to inhibit the reticulospinal tract resulting spasticity. So those fibers responsible for the spasticity are different from the fibers which mediate the muscle power. So if a lesion happens to occur in such a location where only the corticospinal fibers are there, the other fibers are not there, you are going to get hypotonia and not spasticity.
Parietal lesion also can produce hypotonia.
Yeah, parietal lesion also can produce hypotonia. What is it is correct. Because if it is that the parietal area also contains some fibers responsible for the muscle tone, if that area is spared, you can have hypotonia. You're right.
And how can we explain the hypotonia in cerebellar lesion, sir?
That is an entirely different one. That is because of the influence of the cerebellum onto the vestibular nuclei, inhibiting that thing produces hypotonia. That is a different mechanism. Because the facilitatory tract is a vestibular spinal tract, the inhibitory tract is lateral reticular ventromedial tract, and the vestibular spinal tract is a facilitatory, lateral tract is the inhibitory. So that is influenced by the modulated by the anterior lobe of the cerebellum. That is why you can get hypertonia. Similarly, chorea can also produce hypertonia. Caudate lesions can also produce. That's nothing to do with the pyramidal spasticity. Okay, so this I think the same thing. I think I also, how can you get upgoing plantar in the person the same thing the question is asking. And I think depends upon the severe. They have already shown this line. Okay, now what do you want to do now? What do you want
MRI
to
of
investigate?
MRI.
Okay. Okay, this is MRI. It shows a diffuse hyperintensity in the epiconus, maybe in the conus also, and another lesion in the quadriceps. See this one here and here. Also the axial cut. This is the epiconus, which is shown on the left side. D11. You can see the D11 here. On the left side here, arrow showing that thing that is enlarged. D11 is enlarged. D and D12 not much. Then D12 not much. Then below D12 there is another. You can see that area. Compressed in the quadriceps roots. D12 level. And then below that L2, L1 level below is normal. So there is lesion in the epiconus, not in the conus, then another one in the upper part of the quadriceps. Here. This is upper part of the quadriceps here. That is shown here also. This is one here, this is the quadriceps, the lower one. This again you can see that. This one. This is the T1. The epiconus lesion is coming from D8 downwards. D8 down. This is the D8, D9, D8, D9, coming up to D10. So patients internally lesion the epiconus as well as round mass lesion the upper quadriceps. So what is responsible for the patient symptom? Obviously, both may be contributing. We do not know. Because epiconus lesion all cannot explain that. The quadriceps also can explain that.
Quadriceps, we cannot explain the plantar, sir.
Pure quadriceps, no, of course. Both are there in this patient. Pure quadriceps cannot explain the plantar at all. If you get a plantar, the lesion has to be inside the cord. No doubt about it. You cannot get a quadriceps, I mean, abdominal quadriceps at all. Now, what I'm trying to say, which is supposed for the patient symptom, except for the abdominal weakness part. A total sparing of the sensory with element weakness more with the quadriceps rather than with the epiconus.
Did it have any contrast enhancement in the MRI?
I think it was there. This only picture available. It was there. This is the only picture I have with me.
Why no bladder symptoms?
Bladder, to suppose you got epiconus lesion. If it is a conus lesion, definitely it's a bladder center is there. You are going to have a LMN bladder. In epiconus lesion, bladder involvement can occur provided that lesion involves the medial part of the pyramidal tract. Because the bladder fibers are running along the pyramidal tract, or in fact, actually not part of the pyramidal tract. That fibers which control the bladder fibers is located in the medial part of the pyramidal system. So the medial part of the pyramidal tract is affected, you can bladder if epiconus is there. Lesion confined to the central part of the cord will not produce bladder affection even in the epiconus. I think I'll show that picture once again to clarify that doubt. So suppose the lesion is here. Okay. That can put, suppose this is epiconus I am drawn here. That will not produce bladder. That produce element weakness only because it's compressed in the anterior concept. If it is going like that, extending the pyramidal tract here, that can produce bladder.
Okay.
Because the bladder fiber is situated medial.
Yes.
Okay.
So
So,
usually bladder fibers will be on either
Whole
side of
code is
the
involved.
pardon, can you
In the transverse plane, the whole code is involved, but there is no sensory involvement at all.
No, that's what I said initially. That is, you expect a sensory involvement if the central part is affected, the lesion has to be in the thoracic, any other cord, but may not be there in the case of a epiconus region because the slant of the fibers which already explained.
But the complete spinal cord is involved, sir. Not only the central.
Yeah, but you mean from the radiologically. So that signal change in the radial does not mean it's a complete involvement or not. That depends upon the structure itself. So for example, if you think in ATM, acute transverse myelitis, only one level of cord, level may be D4. You find the hyperdensity going from top to bottom. From C1 to L1, you can get hyperdensity, but we have only lesion in the dorsal cord. So that finding the hyperdensity in the cord does not mean that the lesion is actually there. Partly contributed by the demand.
So usually we have bladder fibers on either side of the central canal, sir. So the lesion.
No. Bladder fibers are not in the central canal. It is in the lateral funiculus in the medial part of the peripheral tract. See, if you got a syringomyelia, because I know why you're telling like that, because you often taught that early bladder involvement is syringomyelia, correct? That's
yes.
internally, but that is not because of the fact that these leads in the bladder fibers situated in the grammatic funiculus. Also that thing. Eh? Just one more thing, that particular picture. Okay, imagine here the bladder fiber. This can you see this thing? Pointer. Yeah.
Yes, sir.
This is the perimeral tract. Okay, this is the perimeral tract. The bladder fibers are here. The middle part of the pyramid, not here. Got the point? So lesion here will not produce a bladder involvement. So syringomyelia in the red area where the syringomyelia will not produce bladder unless it has extended to the middle part of the pyramidal tract. You got the point? Then only bladder is affected. So in early bladder and late bladder in terms of intra and extramedullary is relation not due to the duration of illness, only relation the pyramidal tract is affected or not. In the extramedullary, the lowly pyramidal fibers are all affected before the bladder is affected because that is innermost immediately. Intramedullary, early bladder involvement because in relation to the weakness, to pyramidal weakness. Before the pyramidal weakness of the other limbs comes, bladder is likely to be involved with a symmetrical involvement.
Okay.
Yeah. That is why early and late in relation to the pyramidal weakness and not in relation to the duration. So, in fact, unfortunately, this biopsy turned out to be astrocytoma. This is the biopsy ganglioma with anaplastic changes in both the lesions. So, final biopsy report was biopsy internal lesion D11, D8 to D11, diffuse midline glioma, some other grade, even mutant grade. Then subsequently, Dr. Fijo asked for MRI screening, this particular girl. And that MRI showed multiple T2 flare hyperintense lesions noted along the cervical cortical sulci and along the cerebellar folia, possibly CSF drop metastasis. That is the thing with the patient had. Unfortunate girl, she ultimately succumbed to the illness.
Such acute presentation is possible.
Yeah, it's possible. Anybody, some malignancy can produce acute presentation, is very well possible. Especially some highly malignant, rapidly progressive lesion can produce. Okay, I think I'll skip the next case for today. So, any questions? Anyway, we had a good discussion regarding localization of the lesions.
Yes, sir.
Yeah.
Yes, sir.
Thank you, sir.
Okay.
you,
Any
sir.
question? Thank you. Good
Thank you,
night.
sir. Good night.
Thank you, sir. Good
Thank
night.
you, sir. Good night.
Okay,
Good night.
night.
Thank you very much. Thank you very much.
We'll see you next week.
Okay, sir. Sure, sir.
Okay, sure. Okay. Thank you.